So priority examples for action include having a standardized process to screen for sepsis. And we know that this is not going to be a one-size-fits-all. The process at your hospital is going to depend on things like the size of your hospital, the type of patients in your hospital, the resources available. But one thing that's important for all hospitals is to ensure that this process is well integrated into the existing clinical workflow to make sure that this happens consistently for every patient. The second thing we point out in this example is that it's important to consider for newer tools, such as machine learning tools, to not project bias by gender, race, or ethnicity in the rollout of these algorithms. The next priority example is having a hospital guideline for management of sepsis that addresses key aspects of management, including screening, clinical evaluation of patients at risk for sepsis or with suspected sepsis, diagnosis of sepsis, antimicrobial selection and de-escalation, source control, patient and caregiver education, as well as recovery-based practices to set up patients for longer-term recovery and best outcomes after sepsis. Next slide. Additional priority examples include having a hospital order set for the management of sepsis to make it easy to do the recommended practices, having structures and processes to facilitate prompt delivery of antimicrobials, which we know is a key aspect associated with better outcomes from sepsis. So some specific examples of things that hospitals can do to facilitate prompt delivery of antibiotics after they are ordered is to stock common antimicrobials in high-use locations, such as the emergency department or intensive care unit, having processes to immediately process the new antimicrobial orders in patients with sepsis, having order sets that default to having the first administration of antibiotics occur immediately, as opposed to defaulting to sort of the next routine, Q12-hour administration time. And then having pharmacists on site in key locations outside of the pharmacy, such as the emergency department and ICU. Finally, having structures and processes in place to support effective hospital handoffs in patients with sepsis. We know that patients undergo many transitions over the course of their hospitalization, for example, transitioning from emergency department to inpatient wards, ICU to wards, or even between providers as they rotate on and off service. We also know that these transitions are high-risk periods where things can fall through the cracks. And so it's really important to have structures and processes in place, such as standardized handoff processes or documentation templates, to ensure that the key information is passed on and care can be delivered in a seamless fashion to our patients. Next slide. Additional examples of action include having rapid response teams that are trained specifically in recognition and early management of patients with sepsis, having a code sepsis protocol. This is essentially having a huddle of key providers, doctor, nurse at the bedside of the patient who, flags positive for potential sepsis. So you can huddle, evaluate the situation, make a group decision of whether sepsis is most likely, and if so, initiate early management steps. Another example is having a peri-discharge evaluation to support recovery, evaluating for new limitations that are common in our patients after sepsis, reviewing chronic conditions, reviewing medications, screening for social vulnerability, and connecting patients to available resources. Post-discharge care coordination. We know that many patients after sepsis need ongoing care, and it's really important to get this care in a timely fashion. Scheduling those follow-ups prior to discharge and trying to organize these in a way that it's most feasible for our patients to attend those visits, or even having dedicated post-sepsis or post-critical illness follow-up clinics where many of the care can occur in a centralized location are ways to help facilitate recovery in our patients after sepsis. Finally, having structures and processes in place to prevent the development of healthcare-associated infections, which contribute to hospital onset sepsis.
Henry Ford Jackson Hospital is located in Jackson, Michigan, which, for those who are not familiar, is in South Central Michigan. Our city population is about 31,000, and the county population is 160,000. It's a 420 bed hospital, level 2 trauma center with approximately 70,000 emergency department visits a year, which sounds quite high for a community of that size, but we're the only hospital within about 35-mile circumference. So we have a very large catchment area. And we see about 1,400 sepsis cases every year. So if you could go to the next slide. When we first started tackling sepsis, we empowered our nurses in the emergency department to advance and draw lactates. So we have a nurse-driven protocol where if the patient we call it screens positive, meaning they have any of the two following SIRS criteria, which you can see listed on the right of your slide, that they actually order a lactate and send it up to the lab. Now, pending the value of that lactate, if it's greater than 2, they call the physician assigned to that patient and have a huddle like Dr. Prescott was talking about. So ideally, this occurs at the bedside, but sometimes we all know that that's not possible given if people are busy or what have you. So it's at least a phone call. And the 3 things that we discuss are the IV fluids, the antibiotics, and the next steps for the patient. One thing we noticed when we first implemented this protocol was that we were still having quite a delay in antibiotic administration. And so one of our residents actually did a little project on that and found that many of the antibiotics that we were using weren't actually located in the Pyxis. They had to come from pharmacy. So what we did was we identified the most common antibiotics and made sure they were in our bedside Pyxises so that they could be administered relatively quickly. So if you could go to the next slide. So this is a copy of a paper form that we implemented to kind of outline the process that I just described. And these are sitting around in our emergency department. The nurses can pick one up, one of the physicians could pick one up. And if you could go to next slide, I zoomed in on a little bit because I realized that might be kind of difficult for people to see. So you can see there's a little checklist on the front of the sheet there that kind of takes you through the SIRS criteria. You could go to the next slide. Thank you. And if patients have organ dysfunction and kind of what the next steps are. If you go to the next slide, you can see the back of the sheet. And this part of the sheet is meant to go with the patient. So it actually has times and kind of next steps, and there's areas for the nurse to initial things to show, kind of check them off, if you will, as you go. Next slide. And you can kind of see how it takes you really basically through the 3-hour bundle as you go down that sheet. If you go to the next slide, one of the more recent things we've done is I get a lot of questions from our physicians. What am I supposed to do in this situation? So we actually borrowed this from one of our other facilities that I spoke with on the phone and came up with this little flow diagram that kind of takes you through a little bubble diagram of the step 1 bundle and what the next steps are. So there's kind of yes and no and where to go and your next steps, orders, etc. And you can't see it on this slide, but on the actual document, we have a lot of Epic dot phrases. We use Epic for our documentation system. Those dot phrases are listed right on this sheet. So for the various steps, the physicians can hit the appropriate documentation phrases that we want in the chart.
So we're a community hospital in Southeast Michigan. We have 366 licensed inpatient beds. We are a level 2 trauma center and a primary stroke center. We're also nationally recognized cardiovascular center of excellence. Recently, we opened a North Tower that has 160 acuity adaptable beds. You can see the picture of our beautiful North Tower on that lower picture that we're quite proud of. We are affiliated with Michigan State University, and with which we have 8 graduate medical education residency programs that span between surgical specialties, medicine specialties, as well as outpatient family practice. We have a pluralistic medical staff model at our hospital. We have both private and employed provider groups. So the intricacies of pluralistic medical staff does lend to some challenges with discharge planning that we will go into a little bit in the presentation. Just to give you an idea of our sepsis volume, for 2022, we had a sepsis volume of discharged patients with a diagnosis of sepsis of over 1,700 patients. The breakdown of that is over 950 sepsis diagnoses, 272 severe sepsis diagnoses, and then 479 septic shock diagnoses. So we certainly take care of a pretty high volume of critical care patients with sepsis. Next slide, please. So this is just a quick overview of the three main elements that are working together for best discharge to home care coordination for our sepsis patients. So the three elements all need to work together in tandem for this to be a successful discharge process. The first element here is the case management team. This is our inpatient case management providers that work in the hospital setting. They will help determine if the patient needs assistance in scheduling their outpatient primary care appointments upon discharge. Then they would connect with the hub, which is external to the hospital. It's part of Henry Ford Health's population health division. And there are coordinators within that population health that will help schedule the PCP appointments post-hospital discharge for our patients with the diagnosis of sepsis. And then the patients themselves are obviously integral to this process. They will receive all the appointment information and education that they need upon discharge. Next slide. So just diving into each of these elements a little bit more thoroughly, the case management team will receive a referral either directly from a consult from a physician, or they'll receive a referral from the nurses working bedside on their daily rounds with our case management and social work teams. Upon referral receipt, the case management team will then go and assess the patient, and they will determine with the patient if they need any assistance in making their PCP follow-up appointment upon discharge. If that is the case and the patient does accept that assistance, then the case management team will then consult with the hub and indicate the patient's primary care physician. And then they will rank the patient's readmission risk. It's part of the order that's placed to the hub. And they will either assign the patient as low risk, medium risk, or high risk. Sepsis in and of itself is considered a high risk readmission rate. So they will be deemed as a high risk. Next slide, please. So when we look at the hub, this is a system-wide group of population health coordinators. They work with all of our hospitals within Henry Ford Health, with the exception of Jackson at this time. So all of our Southeast Michigan sites. They are the ones responsible for calling the primary care doctor's offices for our patients and scheduling those follow-up appointments. The high-risk appointment or the high-risk patients that are deemed on the case management consult will have that follow-up appointment scheduled within 7 days of hospital discharge. If the patient doesn't have an established PCP already assigned, then the hub will work with the case management team and that patient to help identify an appropriate primary care physician for follow-up to ensure that they can help them establish a PCP and a follow-up appointment within that 7-day window. Now, if the hub team is unable to successfully schedule that follow-up appointment, then the hub will contact the patient within 72 hours upon discharge from the hospital to reconnect with them and see if they need any additional assistance or if they have been able to, in the interim period of time, make an appointment to help coordinate that with the patient. Next slide. The patient then will receive their discharge instructions, which we call our after visit summary. That will include, if the hub is able to make that appointment, it'll include the follow-up PCP appointment date and time on those discharge instructions. If the hub was unable to make that appointment for the patient, it'll list that, stating that the patient still needs to call their PCP for a follow-up appointment within the next 7 days. On our after visit summary, we also list the hospital contact number. So the patient has a lifeline back to the hospital to reach back out if they have any issues or concerns that arise between the time they're discharged and when they're able to follow up with their primary care physician, so we can continue to assist them in that interim period of time. We do have a specialized sepsis education guide that was created through our system sepsis committee that is about to go live. It was supposed to go live within the last week or so, but it got pushed back just a little bit longer. But it's a very robust guide that's very patient-centered and very patient-friendly, that gives the patient and their family members and loved ones further explanation of what to look out for upon discharge and warning signs that would prompt them to seek medical care sooner than their scheduled appointment with their PCP. And then the patient themselves will receive a phone call within 72 hours from the hub if they were unable to schedule that appointment prior to discharge, to reconnect with that patient and see what additional support they may need.